Asthma is a chronic inflammatory disorder of airways that causes recurrent episodes of wheezing, shortness of breath, chest tightness, and cough. This mainly happens at night and early morning. The hallmarks of asthma are airway obstruction that is intermittent and reversible, so it's not continuous and not permanent. Chronic bronchial inflammation with characteristic eosinophilic infiltrate, bronchial smooth muscle cell hypertrophy and hyperreactivity, and increased mucus secretion. The major factors contributing to the development of asthma include genetic predisposition to type 1 hypersensitivity, acute and chronic airway inflammation, bronchial hyperresponsiveness to a variety of stimuli. Asthma can be triggered by the exposure to different stimuli, topped by respiratory infections, mainly the viral ones, airborne irritants like smoke and fumes, cold air, stress, and exercise. This figure shows the initial airway response after exposure to one of the inhaled allergen for the first time. The allergen or the antigen will be recognized by antigen-presenting cells or dendritic cells in the epithelial lining. As a result, T helper lymphocytes will be activated and start releasing inflammatory mediators, resulting in IgE production and eosinophils activation and recruitment. Interleukin 4 and interleukin 13, for example, stimulate the IgE production. Interleukin 5 activates the eosinophils, and interleukin 13 stimulates the mucus production. IgE coats the submucosal mast cells. Upon the re-exposure of the mast cells to the same allergen or antigen, two waves of reaction happen. One is the early or immediate phase and the other is the late phase. The early phase reaction is dominated by bronchoconstriction, increased mucus production, and vasodilation. Bronchoconstriction is triggered by mediators released from mast cells, including histamine, prostaglandin D2, leukotrienes, for example, leukotriene C4, D4, and E4, and also by the reflex neural pathways. This figure highlights the early phase reaction, so it happens after re-exposure to an antigen. This reaction is triggered by antigen-induced cross-linking of IgE that is already bound to the Fc receptors on mast cells. Mast cells released a previously performed mediators that will induce bronchospasm, increase vascular permeability, mucus production, and recruitment of leukocytes. The late phase reaction is inflammatory in nature. Inflammatory mediators stimulate epithelial cells to produce chemokines, including the eotaxin, which is a potent chemoattractant and activator for eosinophils. This results in recruitment of T helper type 2 lymphocytes, eosinophils, and other leukocytes, and also amplifying the inflammatory reaction. As I mentioned in the previous slide, the late phase reaction is inflammatory in nature. Leukocytes recruited to the site of reaction, including neutrophils, eosinophils, basophils, lymphocytes, and monocytes, initiate the late phase reaction. Eosinophils release the major basic protein and eosinophil cationic protein that cause damage to the epithelium. Repeated bouts of inflammation will lead to structural change in the bronchial wall. This is called the airway remodeling, which includes hypertrophy of the bronchial smooth muscle, hypertrophy of the mucous gland, increased vascularity, and deposition of subepithelial collagen. This figure shows a comparison of normal airway to the left and an airway involved by asthma to the right. As you can appreciate in the right figure, there is a green layer of mucus overlying the surface epithelium. Asthmatic airways marked by accumulation of mucus in the bronchial lumen. Usually this happens secondary to the increased number of the mucus-secreting goblet cells in the mucosa and hypertrophy of the submucosal glands. The mucosa here is seen just below this thick layer of mucus and shows frequent mucus-secreting goblet cells. Then you can appreciate the thickened basement membrane beneath the epithelium, with intense chronic inflammation composed of eosinophils, macrophages, and other inflammatory cells. Smooth muscles hypertrophy and hyperplasia, along with hypertrophy of submucosal glands, can be appreciated too. So the airways in patients with asthma show the following: increased number of mucus-secreting goblet cells, hypertrophy of submucosal glands, accumulation of mucus in the bronchial lumen, thickened basement membrane, intense chronic inflammation, and hypertrophy and hyperplasia of smooth muscle cells. The first and the most common type of asthma is atopic asthma. It's considered as a classic example of type 1 IgE-mediated hypersensitivity reaction. It usually begins in childhood. A positive family history of atopy and asthma is common. The onset of asthmatic attacks usually preceded by allergic rhinitis, urticaria, or eczema. Attacks may be triggered by allergen in dust, pollens, animal dander, which is the material shed from the animal feather, food, and/or infections. As we mentioned in the previous slides, the initial exposure to an antigen will result in excessive activation of type 2 helper cells that will start releasing cytokines, of which are interleukin 4 and interleukin 13, that starts stimulating the IgE production, interleukin 5 activating the eosinophils, interleukin 13 that stimulates the mucus production. Then IgE coats the submucosal mast cells. Upon re-exposure, the release of the mast cell-derived mediators happen, and this will produce two waves of reaction. The first is the early immediate phase of reaction, and the second is the late phase of reaction. A skin test with a causing agent results in an immediate wheel and flow reaction. The skin prick test, for example, is the most common allergy skin test. So what we do? First, we get a series of tiny drops of the allergen on your back. Then you get a quick needle prick in the skin underneath each drop. If you are allergic, you will get red and itchy rash, especially at the needle prick site. Atopic asthma can be also diagnosed based on the serum radioallergosorbent tests, which is a blood test using radioimmunoassay to detect specific IgE antibodies and then to determine the substances a subject is allergic to. The second type is non-atopic asthma. Here the patient do not have evidence of allergen sensitization, so the skin test is negative. A positive family history of asthma is considered less common in this type. Respiratory infections due to viruses such as rhinovirus and parainfluenza virus and inhaled air pollutants such as the sulfur dioxide, ozone, nitrogen dioxide are common triggers. Although the connections between those exposures and the non-atopic asthma are not well understood, the ultimate humoral and cellular mediators of airway obstruction are the same to both atopic and non-atopic variants of asthma, so they are treated in a similar way. The third type is drug-induced asthma. Several drugs can provoke asthmatic attacks. However, aspirin is considered the most striking example. Patients with aspirin sensitivity present with recurrent rhinitis, nasal polyps, urticaria, and sometimes bronchospasm. The precise pathogenesis is unknown, but it's likely to involve some abnormality in prostaglandin metabolism from the inhibition of cyclooxygenase by aspirin. This type of asthma can be triggered by fumes, dusts, animal substance, chemicals, and gases. This happens after repeated exposures to the causing agent. Examples include farmers, animal handlers, manufacturers of foam mattresses, bakers, food processors, cotton workers, manufacturers of metals.